Hello everyone, I am Dr. Azharul Hassan and I am a cardiologist. Recently, American Heart Association and American College of Cardiology have updated their 2025 guidelines for the management of acute coronary syndromes. Today, we will be going through them. So let's begin. So to begin with, the 2025 ACC and SCAI guidelines for the management of patients with acute coronary syndromes. These guidelines are slightly different from the previous guidelines as they include all of the acute coronary syndromes under one heading, unlike the previous few guidelines in which there was segregation between STEMI and NSTEMI. As I have already introduced myself, I am Dr. Azhar. I am a fellow in interventional cardiology and have done my FCPS in cardiology. So the ACC and AHA framework guides clinical decisions by categorizing interventions based on their risk and benefit ratio. And they call it a class of recommendation. Class 1 is the strongest class, Class 2A is the moderate class, Class 2B is the weakest class. Coming to Class 3, these are the interventions which have either no benefit or they have harm when intervened in a patient. They also provide the quality of support of research, and they call it a level of evidence. So coming to the ACS. ACS generally includes three related clinical settings that basically exist along a continuum of severity. These are unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. One thing that one must always remember that the unstable angina is defined by the transient myocardial ischemia leading to diminished flow in the absence of myocardial necrosis, and it cannot be detected by circulating troponins. In contrast, patients with more prolonged or severe myocardial ischemia are diagnosed with MI and have elevated biomarkers of myonecrosis. So the thing that differentiates an unstable angina from a STEMI and NSTEMI is the increase of the circulating troponins. Patients with NSTEMI now may have a partially occluded coronary artery leading to subendocardial ischemia, whereas the patients with STEMI typically have a completely occluded vessel, and that leads to a transmural myocardial ischemia and then infarction. So this picture basically tells the two continuum of ACS, the STEMI with a completely occluded artery and ECG showing ST elevation MI. And long after that, on this side, we have an NSTEMI where we have a partially occluded artery and there are some changes in the ECG. And it can be either an unstable angina if there are no increase in cardiac troponins, and we label it as an NSTEMI if there's a positive increase in cardiac troponin. The basic pathology that begins is a progressive lipid accumulation and inflammation within an atherosclerotic plaque, which may lead to plaque instability. Rupture of the atherosclerotic plaque and exposure of the plaque contents to the circulation then may culminate in activation of coagulation cascade and subsequent thrombosis. The presence of thrombus may compromise the flow of the myocardium, leading to myocardial ischemia and eventually myonecrosis. This process is, however, dynamic, and thus the patient can rapidly progress from one clinical condition, for example, unstable angina and NSTEMI, towards a STEMI. So let's talk about the different types of myocardial infarction. So the type 1 myocardial infarction is caused by acute coronary atherothrombosis, which is usually precipitated by atherosclerotic plaque disruption, which can be either a rupture or erosion, and is often associated with a partial or complete vessel thrombosis. In contrast, type 2 MI is caused by an imbalance between the myocardial oxygen supply and the demand. Type 3 MI is usually as cardiac death, and type 4 is divided further into 4A, where there is a procedural complication and MI is detected less than 48 hours after PCI. In 4B, it is caused by a coronary stent or stent scaffold thrombosis. 4C, however, is caused by stent restenosis. Type 5 myocardial infarction is in pre-CABG MI and caused by procedural complications detected less than 48 hours after a CABG surgery. For reference, all of the definitions of myocardial infarction that we are going to use in these guidelines are based on the type 1 definition of the myocardial infarction. Here, an important thing that I would like to point out is that the patient transition from being a patient with acute coronary syndrome to the one with more chronic or stable diseases is incompletely defined. Some say it is 1 year, some say 6 months. So it is not clearly defined. But many of the medications indicated at discharge in patients with ACS are similar to those for the management of a patient with chronic coronary artery disease, and hence should be extended more than a year if possible after ACS. So coming to the initial evaluation and management of these kinds of patients, in the pre-hospital assessment and management, it is imperative to do a 12-lead ECG, acquire and interpret it within 10 minutes of the first medical contact to identify patients with STEMI. And in those in which ECG is non-diagnostic of STEMI, serial ECGs should be done. And the patients who are identified to have STEMI, they should be transported to a primary PCI center by the EMS services, and the goal for the first medical contact to first device time should be less than 90 minutes. In patients with suspected STEMI, early advance notification of the receiving PCI capable hospital by EMS personnel and activation of the cardiac catheterization lab and team is recommended to reduce the time to reperfusion. And all of these are class 1 recommendations. Coming to those situations where the time from the first medical contact to first device is not 90 minutes and it is not possible, direct transport to a PCI capable hospital may be considered if the anticipated first medical contact to device time is 120 minutes or less. These guidelines also impart special emphasis on the several care processes that have demonstrated significant reductions in reperfusion times in patients with STEMI. These include pre-hospital catheterization laboratory activation, a single call transfer protocol for patients from a non-PCI facility, and emergency department bypass to transport patients directly to the catheterization lab for those presenting by the EMS to a PCI capable hospital. In particular, the pre-hospital activation of catheterization laboratories has been associated with lower short and long-term mortality in patients presenting with ST elevation MI. Now, as you all know, that acute myocardial infarction is characterized by the rising or falling pattern of cardiac troponin values with at least one value above the 99th percentile reference limit and believed to be caused by myocardial ischemia. So based on this definition, the in-hospital assessment of patients is just similar to those as a pre-hospital setting, that initial ECG should be acquired and interpreted within 10 minutes. And if the initial ECG is non-diagnostic, then CL12D ECGs should be done. The other thing different from outside the hospital is the patients with suspected ACS should have their cardiac troponins measured as soon as possible, and it should be preferably using a high sensitivity cardiac troponin assay. And in those patients with suspected ACS and initial high sensitivity cardiac troponin or cardiac troponin that is non-diagnostic, the recommended time interval for repeat measurements is between 1 to 2 hours for high sensitivity cardiac troponins and 3 to 6 hours for conventional high sensitivity cardiac troponins. Sorry, conventional cardiac troponins. These are some of the ECG findings that you find in the patients with non-ST elevation MI and STEMI. In non-ST ACS, there are usually ST depressions of 0.5 millimeters in 2 or more contiguous leads, or a T wave inversion of more than 1 millimeter, and there is a prominent R wave or RSH more than 1, or transient ST segment elevation. So these comprises the ECG findings of a non-ST elevation MI. Other things like non-specific ST segment and T wave changes, or even normal ECG can also be observed. In STEMI cases, there is a new or presumed new ST elevation of more than 1 millimeter in 2 or more anatomically contiguous leads, and all leads other than V2, V3 more than 2 millimeter in men of age more than 40 years and more than 2.5 millimeter in men less than 40 years of age. And for women, the limit is more than 1.5 millimeter in the leads V2 and V3. So basically, all the leads more than 1 millimeter, and in lead V2, V3 more than 2 millimeter if the patient is a man with age more than 40 years, and 2.5 it is age less than 40 years. And in doubtful cases, we should not forget doing posterior leads, and the criteria for that is an isolated ST segment depression of more than 0.5 millimeters in lead V1 and V3. After that, if we do a posterior ECG and we see an elevation in V7 to V9, that is also diagnostic of STEMI. Other ST segment changes may be observed in other conditions like acute pericarditis, left ventricular hypertrophy, LBB, Brugada syndrome, and right ventricular pacing, Takotsubo syndrome, and early repolarizations, which may obscure the diagnosis of STEMI. One thing more to remember is new or presumably new LBB at presentation occurs infrequently and should not be considered diagnostic of acute myocardial infarction in isolation. Clinical correlation is required here, and a simple LBB, a new LBB in an asymptomatic patient does not constitute a STEMI equivalent. The guidelines also advocate the use of clinical decision pathways as in the previous guidelines, and they have shown to improve the outcomes and direct appropriate use of resources. So in brief, whenever a patient with suspected ACS comes, you do a brief history and physical examination, and if an ACS is suspected, get an ECG done within first 10 minutes and obtain a cardiac troponins. If it is a STEMI, evaluate for reperfusion, and if it is a non-STEMI, do serial ECGs to see if it can evolve into a STEMI, and do cardiac troponins. If high sensitivity, do it in 1 to 2 hours, or if it is a conventional cardiac troponin, do it in 3 to 6 hours. CDP is used to define the risk and the subsequent plan. Different risk stratification tools are GRACE, STEMI for acute unstable angina and NSTEMI, and TIMI risk score for STEMI. So coming to the management of patients with cardiac arrest. So the 2025 guidelines say that if a patient has cardiac arrest and has STEMI, and he has been resuscitated fully, he must be transferred to a primary PCI capable center. Or if the patient has been resuscitated after cardiac arrest in STEMI and is non-comatose, or who are comatose with favorable prognostic features, they should also undergo primary PCI as it improves survival. It has a class 1 recommendation. Coming to those patients who had STEMI and cardiac arrest but are comatose with unfavorable prognostic features, they may also be considered from primary PCI based on individual assessment, and it has a class 2B recommendation. The unfavorable prognostic factors include no bystander, CPR, an unwitnessed arrest, no shockable rhythm present, CPR of more than 30 minutes, time to ROS is more than 30 minutes, arterial pH is less than 7, and age more than 85 years of age, or if the patient is end stage renal disease. For patients who are resuscitated and comatose and they do not have any evidence of STEMI, immediate angiography is not recommended due to lack of benefit, and it has a class 3 recommendation. Numerous studies have been done which show that these kind of patients do not have any improvement in survival or neurological recovery at 6 months. Coming to the oxygen therapy, so the guidelines recommend that if a patient has ACS and confirmed hypoxemia with oxygen saturation of less than 90%, only then supplemental oxygen should be given, and it has class 1 recommendation. But if the oxygen saturation is more than 90%, routine administration of supplemental oxygen is not recommended in these patients, and it has class 3 recommendation. Management of patients with pain is of utmost importance, and these are the guideline recommended drugs that can be used for patients with chest pain. Nitroglycerin can be given sublingually and IV, but needs to be taken care of for the BP. And other than that, morphine and fentanyl can also be given. Although there are concerns that opioids delay the gastric and intestinal absorption of orally administered P2Y12 inhibitors, thereby delaying their pharmacodynamic effects in patients with PCI. However, clinical relevance of these pharmacodynamic findings remain disputed. So these can be given. And use of non-aspirin, non-steroidal anti-inflammatory drugs should be avoided for the management of patients with suspected ischemic pain whenever possible. Guidelines recommend use of aspirin at the dose of 162 to 325 milligrams in patients with ACS without an absolute contraindication as soon as possible on the presentation, irrespective of the final management strategy. So all patients who come with ACS must get an aspirin. It is a class 1 recommendation, and it should be followed by a daily maintenance dose. In patients who cannot take oral medication, rectal or intravenous administrations are options for administration, and current evidence support the use of uncoated low-dose aspirin 75 to 100 milligram for daily maintenance therapy. The 75 to 100 milligram daily dose of aspirin basically exceeds the minimal effect dose required for platelet thromboxane A2 suppression, allowing for some inter-individual variability in drug response. For patients in whom a history of aspirin hypersensitivity is reported, aspirin desensitization is preferred whenever possible to allow for initial use of DAPT. Coming to the second part of the DAPT, the oral P2Y12 inhibitors, like previous guidelines, in patients with ACS, oral P2Y12 inhibitors should be administered in addition to aspirin to reduce MACE. And those with the history of stroke or TIA, prasugrel should be avoided. It has class 3 recommendation. During in-hospital management of patients with non-ST elevation MI, patients who are going PCI in non-ST elevation MI, they should get a prasugrel or ticagrelor. And those who cannot be given a prasugrel or ticagrelor, clopidogrel should be given in those kind of patients. And in patients with non-ST elevation MI who are managed without planned invasive evaluation, ticagrelor is recommended to reduce the MACE. Coming to the group of patients for which you have planned to do an angiography more than after 24 hours, upstream treatment with a clopidogrel or ticagrelor can be considered given a class 2B recommendation. So in basic, in non-ST elevation, ticagrelor or prasugrel gets class 1 recommendation, and if they cannot be given, then clopidogrel can be given. And in those in which you have planned for intervention after 24 hours, you can give upstream clopidogrel and ticagrelor. Similarly, in patients with STEMI, the class 1 recommendation is for prasugrel and ticagrelor, and if they cannot be given, then comes the role of clopidogrel. Especially in patients with STEMI with fibrinolytic therapy, clopidogrel has class 1 recommendation. There has always been a lot of talk about the upstream use of beta blocker DAPT, and this question still remains unanswered in these guidelines. A meta-analysis of trials of clopidogrel in patients with ACS undergoing PCI found that pre-treatment with clopidogrel significantly reduced risk of 30 days cardiovascular death or MI. However, less is currently known about the need of pre-treatment in the area of more potent P2Y12 inhibitors, which have a more rapid onset of action, and so it remains unknown whether a benefit exists for administration of ticagrelor prior to PCI in patients with STEMI. And that is basically the reason why routine pre-treatment in patients undergoing early invasive management strategy less than 24 hours is still not recommended by these guidelines, but they can be given if intervention is planned for more than 24 hours later. This table I know you must be knowing already. The different antiplatelet that can be given: aspirin, clopidogrel, prasugrel, and ticagrelor, and their doses are also given in this table. This table basically summarizes what we have learned previously, that PCI for STEMI or NSTEMI should get aspirin along with ticagrelor or prasugrel, and if they cannot be given, then clopidogrel. For patients who have undergone CABG after ACS must get aspirin or ticagrelor or clopidogrel, and continue aspirin during PCI and start P2Y12 inhibitor when safe post-operatively. So CABG patients with ACS get ticagrelor or clopidogrel after the cabbage. And in those in which no planned invasive evaluation is planned, they can get an aspirin with a ticagrelor, and those with fibrinolytic system should get an aspirin and clopidogrel. This table tells us about the duration of the antiplatelets for patients who require cabbage and when to stop them. For elective cabbage, clopidogrel must be stopped 5 days before surgery, and for urgent cabbage, interruption for at least 24 hours is ideal. For prasugrel, in case of elective cabbage, 7 days interruption is a must, and in emergency cases, at least 24 hours is again ideal. And same for ticagrelor, that for elective cabbage, interruption for 3 to 5 days before surgery is recommended, and in urgent cases, interruption of at least 24 hours is ideal, and proceeding earlier than 5 days may be reasonable. There has been a lot of talk about intravenous P2 white valve inhibitor, the cangrelor, and it has a class 2B recommendation in patients who have not been previously given a P2 white valve inhibitor. So they can get a P2 white valve inhibitor in IV form during PCI. And this table shows a transition from intravenous cangrelor to oral P2 white valve inhibitor. Clopidogrel must be given with the loading dose immediately after discontinuation of cangrelor. Prasugrel similarly must be given in a loading dose of 60 mg after discontinuation, and ticagrelor in a loading dose of 180 milligram, and it can be given at any time during or immediately after discontinuation of cangrelor. So coming to another favorite drug, especially in the past, the GP2B3A inhibitors. These agents were first evaluated before the contemporary antiplatelets and interventional strategies, and in an era when the time to coronary revascularization was substantially longer than today. Thus, limited data are available for GP2B3A receptors in patients receiving more potent P2 white valve inhibitors, and in those receiving earlier PCIs with contemporary drug-eluting stents that have a lower risk of stent thrombosis than prior generation of stents. In current practice, the role of GP2B3A inhibitors is largely limited to the adjuvant use at the time of PCI in patients with large thrombus burden, or as a rescue or bailout therapy in patients with PCI complications such as no reflow, persistent or recurring thrombus at the lesion. So it gets a class 2A recommendation in these kind of patients. And the routine use is like the previously in guidelines has a harm. So 3 recommendation for that. Coming to anticoagulation, unfractionated heparin is recommended in patients with non-ST elevation MI, and in those in which an early invasive approach is not anticipated, enoxaparin or fentaparinox can be given. All of these have a class 1 recommendation. And in patients who are undergoing coronary revascularization, again, use of heparin has class 1 recommendation until the complete revascularization is done. Now coming to the patients with ACS who are undergoing PCI, in these patients unfractionated heparin is recommended, and in patients with STEMI, biliverdin gets a class 1 recommendation. However, in patients with non-ST elevation MI, biliverdin gets a class 2B recommendation. Similarly, in patients with ACS, intravenous enoxaparin may be considered as an alternative to unfractionated heparin at the time of PCI to reduce ischemic events. Important thing to remember, like previous guidelines, fondaparinux should not be given to patients alone when a PCI is anticipated because of the risk of catheter thrombosis, and it gets a class 3 recommendation. And for patients who have undergone fibrinolysis for STEMI, they should be anticoagulated for maximum of 8 days or until a revascularization is performed. And in these patients, enoxaparin can be given, and if the patient are intended not to undergo any invasive procedure, then fondaparinux can be given as well. This table shows the doses of different anticoagulations in ACS. Coming to the lipid management, these guidelines recommend use of high intensity statin therapy to reduce the risk of MACE. The target must be less than 70 milligram, per deciliter, and if this target cannot be achieved with statin therapy alone, then a non-statin lipid-lowering agent is recommended to be added. And in patients with ACS who are statin intolerant, non-statin lipid-lowering therapy is recommended, and it has got a class 1 recommendation. The target is 70, and it is also recommended to achieve a target between 55 to 69 milligrams per deciliter by adding a non-statin lipid lowering therapy, and it has a class 2A recommendation. In patients with ACS, the concurrent initiation of ezetimibe in combination with maximally tolerated statin may be considered to reduce the risk of MACE. So the target is 70, but to achieve somewhere between 55 to 69, you can also add a non-statin lipid lowering drug. This table beautifully summarizes the use of statins or non-statins to lower the lipids. If get a baseline lipid profile done, and if the patient was not already on statin or on moderate or low intensity regimen, give him high intensity statin therapy, and you can consider to add ezetimibe to that and reassess lipid profile 4 to 8 weeks after discharge and adjust therapy as required. If the patient was already on maximally tolerated statin regimen and his LDL cholesterol was less than 55 milligrams per deciliter, continue with the high intensity dose. If it was between 55 to 69 milligrams per deciliter, consider addition of a non-statin LDL therapy. And if the LDL was more than 70, then apart from high intensity maximally tolerated statin therapy, you have to add a non-statin lipid lowering therapy as a class 1 recommendation, and then again reassess after 4 to 8 weeks. And in patients who are intolerant or if have refusal to use of lipid lowering statins, then you can add a non-statin lipid lowering drug and then reassess, just like you do for statins. This table summarizes the doses of different lipid-lowering drugs. Point to remember is for high-intensity therapy, you have to give 40 to 80 milligrams of atorvastatin to the patient or 20 to 40 milligrams of rosuvastatin. So these are the preferred drugs for high-intensity therapy. Other than that, ezetimibe, volocumab, lidocaumab, inclisiran, and bempedoic acid are also recommended. Coming to beta blockers, they get a class 1 recommendation for early initiation in patients who do not have a contraindication, so they must be given early in less than 24 hours in oral form to reduce the risk of infarction and ventricular arrhythmias. Similarly, ACE and ARBs in patients with high risk features of ASCS with an EF less than 40%, hypertension, diabetes, and STEMI with anterior location should be given an ACE and ARB to reduce the risk of death and MACE. And in patients with ACS and EF less than 40% with heart failure symptoms and diabetes, a mineralocorticoid receptor antagonist is also indicated. Also, in patients with ACS who are not considered high risk, an oral ACE or ARB is reasonable to reduce MACE. Sacubitril and valsartan combination is also considered safe to begin with instead of ACE and ARBs early after MI, according to these guidelines. These guidelines also recommend that all communities should create and maintain regional systems of STEMI care that coordinate pre-hospital and hospital-based STEMI care processes with the goal of reducing total ischemia time and improving the survival of patients with STEMI. These pictures represent some of the things that we have already discussed and transfer of the patients using specific systems. These guidelines again represent that patients presenting with STEMI of less than 12 hours must get a primary PCI done within less than 90 minutes after, if it is coming from a primary PCI center, and more within 120 minutes with patients who require hospital transfer to improve survival. And in patients who are in cardiogenic shock or hemodynamic instability, emergency revascularization of culprit artery by PCI or CABG is indicated to improve survival irrespective of the time from the symptoms onset. If you are going to do a primary PCI within 12 to 24 hours, it will be considered a class 2A recommendation. And after 24 hours, if the patient has ongoing symptoms of ischemia or life-threatening arrhythmias, then primary PCI is a reasonable option and is again given a class 2A recommendation. For patients who have a totally occluded infarct-related artery for more than 24 hours after symptoms onset and are without evidence of ongoing ischemia, acute severe heart failure, or life-threatening arrhythmias, primary PCI should not be performed due to lack of any benefit. Coming to the urgent CABG surgery, CABG is only recommended in patients, urgent CABG is only recommended in patients in which after diagnosis of STEMI, PCI is not feasible or successful with a large area of myocardium at risk. Only in this subset of population, we should go for an urgent or emergent CABG, and it has got a class 2A recommendation. This table again shows how to treat a patient with the STEMI in case of a non-PCI capable center. So like we have already discussed, if the distance to a primary PCI center with first medical contact to device activation is less than 120 minutes, the patient should be transferred to a primary PCI capable hospital. If the onset of symptoms is less than 12 hours and anticipated delay to primary PCI is more than 120 minutes, then pharmaco-invasive strategy with the use of fibrinolytic therapy should be done, and it has got a class 1 recommendation. In patients with STEMI and symptoms of onset between 12 to 24 hours, transfer to a PCI capable center for primary PCI is reasonable, and it has got a class 2A recommendation. And patients with only ST segment depression, except when true posterior STEMI is suspected, fibrinolytic therapy should not be administered due to the risk of hemorrhagic stroke and major intracranial bleed. So you have given a patient fibrinolytic therapy in a non-primary PCI center, and next comes a question when you want to transfer the patient. So a patient with STEMI transferred to a PCI capable center immediately after fibrinolytic therapy. So you have to immediately transfer that patient to after fibrinolytic therapy, and it has got a class 1 recommendation. And in patients with STEMI with suspected failed reperfusion after fibrinolytic therapy, immediate angiography with rescue PCI is recommended to reduce the risk of death and recurrent MI. And in patients treated with fibrinolysis, early angiography between 2 to 24 hours with intent to perform PCI is recommended. So if you have already given fibrinolysis to a patient, it has been successful, you have to transfer him immediately to the primary PCI center, and in that PCI center, angiography must be done within 2 to 24 hours. And if the patient had a unsuccessful reperfusion, then again you will have to transfer the patient for rescue PCI. These are the doses of different fibrinolytic therapy agents used for STEMI. SK can also be given, although not mentioned here because it is unavailable in America right now. And these are some of the absolute and relative contraindications of fibrinolysis. Coming to the selection of routine invasive versus selective invasive strategy. So in patients who are at intermediate or high risk of ischemic events and are appropriate candidates for revascularization, an invasive approach with the intent to proceed with revascularization is recommended during hospitalization to reduce MIS. However, in patients with STEMI who are at low risk of ischemic events, either routine invasive or selective invasive approach is recommended to help identify those who may require revascularization and to reduce MIS. And in those in which we have decided for an invasive strategy, if the patient is having refractory angina, hemodynamic or electrical instability, then an immediate invasive strategy should be opted for that person. And for patients who are at high risk of ischemic event, it is reasonable to choose an early invasive strategy within 24 hours to reduce MIS. And patients who are not at high risk and are intended for invasive strategy, it is reasonable to perform angiography before hospital discharge to reduce MIS, and it has got a class 2A recommendation. The relative contraindications of routine invasive approach include patients with high bleeding risk on DAPT, severe thrombocytopenia with the platelet count of less than 50, and advanced kidney disease but not on dialysis, acute renal failure, limited life expectancy of less than 1 to 2 years, advanced dementia, known coronary anatomy that precludes PCI and CABG surgery, and patient preference. And so in these kind of patients, you can go for a selective invasive approach. So this slide again shows that for very unstable and high-risk patients like those with cardiogenic shock, severe signs and symptoms of heart failure, refractory angina, and hemodynamic or electrical instability, immediate and invasive strategy with angiography done in less than 2 hours is recommended. Class 1 for high-risk patients with graves risk more than 140 and rising cardiac troponin levels with ongoing dynamic ST segment changes, routine invasive angiography in less than 24 hours is recommended. For intermediate risk patients with a grace risk of 109 and 140, angiography can be done before hospital discharge in less than 72 hours. And for very low risk patients, routine invasive or selective invasive approach can be taken. So for PCIs, radial approach is preferred and given a class 1 recommendation over the femoral approach. Use of routine aspiration thrombectomy is still class 3 and is not recommended, and use of intracoronary imaging, especially for the implantation of stent in left main artery or in complex lesions with the use of IVUS and OCT is recommended and has got a class 1 recommendation. Now coming to the management of multivessel disease in STEMI. In selected hemodynamically stable patients with STEMI and multivessel disease after successful PCI of infarct-related artery, PCI of other non-infarct-related arteries is recommended to reduce MACE, and it has got a class 1 recommendation. For patients who have STEMI and complex multivessel disease after successful PCI of the infarct-related artery, elective CABG can be considered for the remaining non-infarct-related arteries, especially if it is involving left anterior descending artery or the left main stem, and it has got a class 2A recommendation. For patients with low complexity, we can do the non-infarct-related arteries during the time of primary PCI, and it has got a class 2B recommendation. Again, the shock, if a patient is in shock, do not touch the non-culprit artery. It has got a class 3 level of recommendation. Coming to the patients with multivessel coronary artery disease in STEMI, if there is a disease that can be managed with bypass, it should be managed with bypass, and basically revascularization in STEMI in multivessel disease is recommended either by CABG or PCI. And for patients without left main stem disease and who are not intended for a CABG can undergo culprit lesion PCI along with PCI of non-culprit lesions during the index procedure. And for patients in whom multivessel PCI is being considered, physiological assessment of non-culprit stenosis is considered to be a class 2B recommendation. In patients, again, with STEMI and cardiogenic shock, intervention in non-culprit vessels is a class 3 recommendation. So in non-ST elevation MI and with multivessel disease, patients who must be considered for a CABG are the patients who have significant left main stenosis with high complexity of coronary artery disease, patients with multivessel CAD with complex or diffused CAD, and the patients with diabetes mellitus and multivessel disease with the involvement of LAD and multivessel CAD or complex left main CAD with severe left ventricular dysfunction. So these are the patients for whom you should consider going for CABG instead of PCI in patients with non-ST elevation MI. Regarding revascularization with ACS in cardiogenic shock, in patients with acute coronary syndromes at cardiogenic shock or hemodynamic instability, like emergency revascularization of the culprit vessel by PCI or CABG is indicated, whereas the PCI of non-infarct related artery is not recommended. It is class 3. Coming to one of the important changes of ACS 2025 guidelines is that in patients with STEMI and severe or refractory cardiogenic shock, insertion of a microaxial intravascular flow pump is reasonable and has now been given a class 2A recommendation. So this is a change from the previous guidelines that microaxial intravascular flow pumps like Impella have gotten a class 2A recommendation in patients with cardiogenic shock and STEMI. Similarly, these short-term devices can be used as a bridge to surgery in patients with mechanical complications. Routine use of intra-aortic balloon pump or VA ECMO is not recommended for patients with cardiogenic shock. This is one thing that one must keep in mind. Mechanical complications of ACI must be managed in a hospital with cardiac surgery expertise, and like we have previously discussed, the mechanical support devices can be used as a bridge to surgery. The picture here below shows some of the cardiac complications like pulmonary muscle rupture, contained rupture, ventricular septal rupture, and free wall rupture, and how these present in clinical settings. Coming to the use of cardiac devices, uh, for ventricular arrhythmias, a patient who is having an LVEF of less than 40% at least 40 days post MI and at least 90 days post revasc should be considered for an ICD. Similarly, patients with post ACS should be considered for ICD if they have a ventricular arrhythmia more than 48 hours and within 40 days post MI to improve the cardiac survival, and it has got a class 2A recommendation. But the use of temporary variable cardioverter defibrillators is uncertain in patients with EF less than 35 to improve survival. It has got a class 2B recommendation. For patients with bradyarrhythmias, the guidelines say that if the patient has sustained evidence of second degree Mobitz type 2 AV block, high grade AV block, alternating bundle branch block, or third degree AV block, persistent or infranodal, then permanent pacing is indicated in these patients. These are some of the guidelines regarding prophylactic ICD implantation that at EF less than 30% and patient with NYHA 1, 2, and 3 should be considered for ICD provided that they have a survival of at least 1 year or more. And similarly, if the EF is 31 to 35%, then NYHA 2 or 3, and if EF is less than 40, then inducible VT is an indication of placement of a prophylactic ICD. Uh, After MI, pericarditis is also common, and diagnosis is made with the presence of pleuritic chest pain and one or more of the following criteria. You can either hear a fictional pericardial rub on auscultation, there can be electrocardiographic evidence, or there can be a ongoing pericardial effusion on echo. All of these, any of these, if present with a pleuritic chest pain, will help in the making the diagnosis of a pericarditis. And additional therapies during pericarditis or late persistent pericarditis include use of high dose aspirin up to a dose of 500 to 1000 milligram every 6 to 8 hourly until the symptoms improve, and colchicine at a dose of 0.5 to 0.6 milligram once or twice daily for 3 months is also recommended in these patients. These patients must be managed in a cardiac intensive care unit, and that is also class 1 recommendation. ACS patients should be uh, transfused blood to achieve a hemoglobin level of at least 10 grams per deciliter or more. It has a class 2B recommendation. Uh, Patients with ACS must be monitored in a telemetry monitoring unit. It has also got a class 1 recommendation, and prior to discharge, an LVEF must be checked. The essential components of patient education include telling them the reason for hospitalization, tailoring decision for lifestyle modification, telling them about their medications, their symptoms management, how to return to a daily routine, their psychosocial considerations, and follow-up care. Center-based cardiac rehabilitation program has got a class 1 recommendation for reducing death, MI, and hospital admissions, and a home-based cardiac rehab program has got a class 2A recommendation. This slide shows the guidance for ACS discharge best practices. The core components of cardiac rehabilitation include a patient assessment, followed by nutritional counseling, the weight management counseling, blood pressure management, lipid management, diabetes management, tobacco cessation, psychosocial management, physical activity counseling, and exercise training. These are the core components of the cardiac rehabilitation patients post ACS. Uh, Now coming to DAPT strategies in the first 12 months post-discharge. uh, after the after the discharge, patient must be recommended to use DAPT for at least 12 months post-discharge. Now, in patients who have a tendency to bleed, they can be shifted to monotherapy ticagrelor after 1 month if they have tolerated the DAPT. And in high-risk patients with GI bleeding risk, should be given a proton pump inhibitor, and it has also got a class 1 recommendation. In patients with ACS undergoing PCI, de-escalation of DAPT, like switching from ticagrelor or prosigyl to clopidogrel after 1 month, may be reasonable to reduce the bleeding risk, and it has got a class 2B recommendation. Whereas ACS patients who have undergone PCI and are at higher bleeding risk, they can be transitioned to a single antiplatelet, either aspirin or P2Y12 inhibitor after 1 month to reduce the bleeding risk, and it is again a class 2B recommendation. Academic Research Consortium for high bleeding risk criteria after PCI is shown here, and if there is presence of at least one major or any two minor criteria, then that it means that the patient has an increased risk of bleeding, and in that case, the DAPT can be modified. Those patients who require anticoagulation post-discharge, uh, they can continue after 1 to 4 weeks. Aspirin can be discontinued with the continued use of P2Y12 inhibitor, preferably clopidogrel along with the oral anticoagulation, and it has got a class 1 recommendation. Now coming to the last few slides, like we have already discussed, lipid levels must be reassessed after 4 to 8 weeks, and treatment strategy must be redefined after that. There's a increasing evidence of colchicine in patients with acute CS, and in patients after ACS, low dose colchicine may be reasonable to reduce risk of MACE, and it has got a class 2B recommendation. Annual influenza vaccine must be given to patients who do not have any contraindication with ACS to reduce the risk of MACE. So basically, this concludes the review of ACC AHA 2025 guidelines for acute coronary syndromes. There are some gaps in evidence, like the risk scores that need more data on them, and then what is the effectiveness of fibrinolysis or primary PCI in stable patients who are symptom free 12 to 48 hours after ST elevation MI, and it also do not tells us about how frequent the telemetry monitoring should be done in patients with ACS. Then again, one of the biggest evidence gaps, I must say, would be the lack of clarity on preloading with the novel or the newer P2Y12 inhibitors. These guidelines do not help us in defining that, and it also does not tell us this document does not tell us about the use of other drugs like sacubitril valsartan, non-statin lipid lowering therapies, or GLP-1 inhibitor receptors, etc. The clinical benefit of beta blockers in the setting of patients with STEMI requires further studying, and the need to revascularize the multivessels in ACS. It can be guided by angiography or physiology is also a matter of debate. The optimal strategy for patients who have more complex anatomy is not clear, and when we should label a patient with uh, ACS to be now in a CCS picture, and when to de-escalate antiplatelet therapies is also not clear. So these are some of the uh, gaps that need to be filled in by by the future documents and trials. So that brings me to the end of this lecture, and for more lectures please do visit my channel and subscribe to my channel. Thank you.